Awesome. Thanks, Ash. Thanks, sponsors. We got a great night tonight, everybody. If you guys haven't heard JT talk before, you're in for a treat. You can see he came straight from the OR to meet with us. It's such an honor to have you here, JT. I'm going to introduce everybody else real quick, and then I may let Chuck introduce you. I pulled up this huge biography. It would take about half the session to even go over it. So I may have Chuck just give you a quick, brief intro. But
Mostly made up, Rob.
Is it? I'm Rob Manske from Wichita State University. Barb, introduce yourself real quick.
Barb Hugenboom from Grand Rapids, Michigan. I'm the editor-in-chief of IJSPT. We're glad you're all here.
Billy.
Phil Page, professor, Fran Yu in Baton Rouge. Thanks for being here. Thanks, Doc. Thanks for George and Chuck, you guys being here. And of course, thanks, Ashley, for the great new website. Thank you so much for pulling this together. And of course, Dr. Voigt down there for pulling us all together.
Yeah. Dr. Voigt, do you want to introduce yourself since you're on the panel today?
Yeah, I'll do that, Rob. Mike Voigt from Nashville, Belmont University. And it's just great to be on. We usually mess this up every week, every month we do it. So I think we have consensus. We are coming on our 34th. 34. So we're all in agreement. So if that wasn't the right number, well, at least we're all on the same page. And I think it's great to have, I know we'll introduce them here, but with Chuck, George, and JT, again, legends in our field, what we do. So it's going to be a great night.
General, introduce yourself since you're on here.
George Davies, former Marine, keeping a good eye on our Air Force colleague tonight, keeping him online.
Sir.
Chuckster.
How's that North Carolina guy? He's not talking.
No, hey, look, I get one night to celebrate before the tournament starts, and I'm taking it.
Take it, buddy.
Hey, didn't you guys beat a charity school last night to get in?
Hey, it was the highly ranked Mountain West, Mike.
That's
highly
right.
ranked San Diego State.
Yeah,
that's right. And they don't ask how, they just ask how many.
Right. Chuck Thigpen, fortunate to be here. Long-time collaborator with Dr. Tokish. Goes back for me, started in the early 2000s. We won't tell the story tonight if I can spare it, but Dr. Tokish was leading the orthopedic service at the Air Force Academy at the time he and I met, worked through some research projects together early on there, and have been fortunate to practice with him for a little while here in Greenville. I think most notably, JT, I'll hit a few things. He's led in just about every orthopedic society there is. I think the ones he's probably most proud of is SOMOS, which is just this military collaboration and the award that they just received on shoulder instability work that we'll talk about tonight, and just his work within the military. Most recently, he served as 42nd president of ANA. So he's immediate past president there, and he has served a number of leadership roles in AOSSM, ASES, and the Academy. So currently, he is a professor at Mayo in Scottsdale, leads their orthopedic or their sports medicine division and research there, does a ton in biologics and in reconstructive surgery. And I'm thankful for what he's taught me in medicine, but more thankfully, he's my friend. So I look forward to the discussion night. It will be a ton of fun.
Thanks, Chuck. JT, I told you before we started, but I want to tell you again, man, it's an honor to have you on with us tonight. Thank you very much for joining us.
It's my honor. I really appreciate the chance to be on with some people that have taught me so much. George has been out to Hawaii when I was at Tripler Army, and he would come out and give us lectures on these things. We had very good physical therapy support, but the nature of the military is so transient. So to be able to get somebody with an expertise like he had to be able to share with our group out there, I will tell you, his lectures instantly raised the standard of care in our facility, because we could take it back after his lectures and take it back to our guys and implement it. They were really good about that. So George, I'm forever grateful for you for that. He also, I think, did 100 push-ups in front of all of us the morning of Grand Round. So that was good. And I can talk about Chuck all night, but none of my career, honestly, would be possible without the collaboration that he and I started so very many years ago. And it's fun. It's a little bit fun to be the old guys now, Chuck, where we can kind of sit back and remember when. But it's just been an incredible amount of work. And I guess maybe I might mention that to the young folks that are out there, the partnership between the surgeon and the physical therapist, if you don't have somebody in your life that's that, for me, those physical therapy relationships, with Chuck and with Ellen Shanley, who's unable to join us tonight, and some of our group here in town now, and everywhere I've been, you can't imagine the education that it opens for you. We're going to discuss one of the articles tonight that Ellen came to me and was one of the few, one of the several times in my career where my mind was blown. I was completely wrong about my assessment, and I was supposed to know a lot about it. And just that lesson alone taking me down the road of that, I'll tell you the story on it in a little bit when we get to it. But this ability, we go to the OR, we do our thing, but you guys you have hands on that patient, you see them, you work with them, you listen to them a lot better than we do. And there's an old stat that shows that it's about 8 seconds on average when an orthopedic surgeon walks into their patient's clinic room before we interrupt and start telling them the plan. 8 seconds, right? So we've got the attention span of gnats. We're not very good at that. And the other thing is, people say to us, well, when can I go back, or what should I do? And the truth is, we have no earthly idea except for what you guys tell us. Honestly, like, I covered the hockey team here before they left and went to greener pastures down in Salt Lake, but for 7 or 8 years. And, imagine the orthopedic surgeon comes in and you get a groin injury, which happens all the time. And it's like, hey, doc, when are they coming back? And thank God I'd had my education with Chuck and Ellen back in the day and some of our guys at the academy, but those lessons you don't learn in orthopedic school. And at the same time, I think speed of recovery and sort of sitting down with Chuck and Ellen about, hey, how fast can we push this one post-operatively? Sometimes they really rely on us to say, hey, not this one was tricky. This one, the quality of the tissue that was not as good. This one you can roll with. Let's get after it. That partnership has been more responsible for my success as a surgeon than anything I ever learned in surgery. So with that as a start, I just want to thank you guys. Thank your profession. I will say that Anna has finally gotten smart, the Arthroscopy Association, in that we have opened up a collaborative with physical therapy. So that is going on in Washington, D.C. this year with a specific date. We started that. We rolled that out in Boston last year during my presidency. It was really important to Alan Curtis, one of his key mandates. Many of you guys have gone to the New England Shoulder meeting many, many years, and that always was a partnership. So I can tell you the presidential line all the way through our organization is really looking forward to that partnership. So I hope that we'll see you out in DC as part of Alan's meeting, and hope to be there, discussing these kinds of things as we go. And with that, I say, let's get after it. Let's jump in.
Let's get after it. Let's do it. So JT, you picked 3 articles all on shoulder stabilization, shoulder instability. What before we even start with any of them, what really is it your time in the military that really drove that? I mean, just seeing that so often, or what makes you so interested in shoulder instability?
Yeah, so when I finished my fellowship in 2001, Vail, Colorado, Stephen Hawkins Clinic, and I went to my dream job, which was to go back to the Air Force Academy and look after my team. My coach was still the head coach.
Awesome.
The coach now was my teammate. He looked at me when he walked in the door when he took the job, and he said, "They let you be the doctor?" And I said, "They let you be the coach?" So we've lorded each over the last 15 years or so, but I'll say this was the real weird part about my upbringing was I get to the Air Force Academy to start my job on September 6, 2001. September 11th happens 5 days later.
Oh, yeah. Yeah.
And I'm what the military guys call the FNG. The NG is the new guy. So they said, hey, new guy, pack your bags, you're going. And I thought, oh, wait a minute. I was just in a fellowship in arthroscopy. I haven't even done a trauma case in a year and blah, blah, blah. And they said, you're on the plane. And I was over there the first time for 7 months. And then I deployed a few times after that. And I will say that it was life altering for all of us, 2001. But here's the lesson and why it ties back to your question, Rob. When we were out there, we saw a lot, and a lot of people doing great things. Those young people, I'll tell you what, do not have any weird worries about fears with America, because those young people that are out there defending the line, we could say all we want about now we're old, they don't grow them like we used to, and blah, blah, blah. Not true. You give me that 18-year-old Marine who was hiding in a nest that was protecting my backside on the line for 4 months. I'll take that kid any day of the week, and he's just as good as our generation or the generation before. I promise you that. Unfortunately, there were a lot of devastating injuries out there. And when I came back, I was charged with the idea of this concept of readiness. So about 2000 to 2001, we start realizing how difficult it is to keep a battlefield ready unit on the field. And if you look at it like we do, that the warrior is not very much different than the athlete. They will always put their team above themselves. They have to function at a very high level of physical performance. And I'll tell you what, if they don't, people die. It's not that you lose a game. It's that it's much more, the stakes are more important than that. So when you look at that, and you know, the signature injury of that war, at least in the first 10 years, was blast injuries, right? And that's terrible. They are awful injuries. But I will say this, from a readiness perspective, yes, it's true that a blast injury takes that warrior off the battlefield. But a shoulder instability takes that warrior off the battlefield too. You can't deploy. And we had a lot of blast injuries, but we had 50 to 100 times the number of shoulder injuries in the same year. You get a Bankart operation or you have a shoulder dislocation, you're out, you're lost to the fight. So why shoulder instability in our young practice guys like Matt Preventure, myself, and you know, Dickens and Brett Owens and Dean Taylor and Bob Arciero and all these, the military mafia, if you will, started looking at this and saying, yeah, the ACL or the shoulder injury, the sports injury, that's what's keeping us from fielding the true battlefield ready warrior. It's not the blast injury, although as bad as that is. So if we can solve this injury for the instability case, in this case, and what we've spent our life doing here, and maybe we can get those kids back at a better rate and a better way, then readiness gets improved and we can continue to get warriors on the battlefield.
Awesome. That's an awesome take. Thanks, JT. Let's you guys ready to start for the first article? Okay, let's start with the Dickens. You mentioned Dr. Dickens. So Dickens, successful return to sport after arthroscopic shoulder stabilization versus non-operative management in contact athletes with anterior shoulder instability. I think you're actually on all of these, aren't you, JT? Every one of these? Yeah, you're on every one of them. So
okay.
Yep. So the purpose of the first study was to examine the likelihood of return to sport and recurrent instability based on the type of treatment, either non-operative versus surgery, among the prospective cohort of contact and collision athletes in the season after their index in-season anterior shoulder event. So one of the first questions I want to ask you, JT, is what is the you were talking about all the military athletes. They're really kind of different than just regular athletes and college athletes to some extent, aren't they? I mean, they're not the same people, are they? I mean, like if you talk about state schools or some private school, are they a little bit different? They have a little different mentality?
No, there's a different mentality, all right, that's for sure. And you have to be careful on who you're looking at. For example, when I was at the Air Force Academy, my failure rate was really, really low, like weirdly low. And it gave me a false sense of security. But you had to realize that in order to graduate and get your chemistry degree, or more importantly, your pilot training slot, you had to be physically qualified. So I swear sometimes I could have cut their arm off and they'd have done their 12 pull-ups and their 86, you know what I mean? The stakes were so high for those kids that, you know, and we had dedicated therapists that, I mean, they worked with those kids down, our trainers, that staff is still there, amazing work on that. So that group, I left there and I'm like, well, I must be pretty good. Well, then I get to Tripler Army where we're looking after 3 divisions of soldiers, and their reward, if they get back, is another trip to Afghanistan. And my results went like this. So we learned a lot of lessons. So are they different? You bet. But I will say this: the kids that are the scary ones to me are the young ones, the high school kids. People talk about, oh, I look after pro athletes. I go, well, I do too. I'll tell you, the pro doesn't scare me because he's 26, he's 28, he's starting to get old and stiff like the rest of us. But those of you guys out there that are managing that 18-year-old, that 16-year-old, that 14-year-old, buddy, that's a challenging one because you got a baby bird. You got the 9th grader who comes in to see you, and you guys say, all right, let's talk about, you know, like I know what you guys would do if you got a shoulder unstable patient. One of the first things you're going to do is they walk in the door and you say, show me a single leg squat. And everybody, the orthopedic surgeons go, what are you talking about? I said shoulder. And you say, no. We got to talk about what's really going on. Now, if you can get them to do that, and you know this, Rob, as well as anybody, that 13, 14-year-old kid, he can't do that single leg squat. He's a baby bird. We got a long way to go before we even start talking about the shoulder, right? So I think that is a different animal for sure. And I think in that high school population, even that early college population, even harder.
when we talk about, when we go in a minute, we're going to talk about this is conservative versus surgical after the first time. But as far as surgical goes, what is your preference? Have you've done both open and arthroscopic stabilization procedures, right? Do you have a preference
Yes.
one over the other, and why?
Well, I think a contact athlete, I think the arthroscopic failure rate is higher. We denied that for a long time, but we now know, right, that the problem is it's such an easy and slick and beautiful operation. It looks perfect when you leave the operating room, and then 18 months later, the kid fails sometimes. And that data is almost irrefutable. I love an open bank heart, but many people are looking for arthroscopic choices. Now we have remplissage, and maybe the remplissage has now brought us up to even. I don't know, but the big mistake is if we miss bone loss. So if there's no bone loss in a patient, and I can do an arthroscopic Bankart with a remplissage, early first-time dislocator, I think those results are really good. But you get beyond 1-2 dislocations, and especially if you start trailing into subcritical bone loss in that regard, especially as the kids get a little older and the speed of the game gets faster, I don't think that's enough. And I think we got to start talking about things like open Bankart, ladder J, bone blocks, and those kinds of things.
That's good you bring that up. So my next question was going to be, so if you see a patient, what are the several really key determining factors of whether you perform a ladder J or a remplissage on someone with instability?
Yeah, so that's exactly the right question. Nobody knows quite yet, right? So the ISIS score helps us. That's a different article than the NISIS score that we've got here later. But the ISIS score was Pascal Boileau, 2006, JBJS British, where they try to look and see which ones were the arthroscopic Bankart going to fail in. Under 20 gave you 2 points. If you were a contact athlete, if you were a competitive athlete, if you had hyperlaxity, or if you had bone loss on the humerus or on the glenoid, and then you got a score. And if that score originally was greater than 6, his failure rate, he's a brilliant surgeon, was too high. The French got together and did a combined group on their entire, the French Arthroscopic Association, and they lowered that number to 3. So if you had a score of 3, well, listen, if you're under 20, you get 2 points. If you're a competitive athlete, that's a point. You're already there.
You're already
so I used to ask them, wait a minute, then every single kid that comes through the door, you're doing a ladder J on. And the French said, oui.
Yeah.
But we think that's a little too much. We think that, there's complications with the ladder J. Bob Arciero did an excellent study where they looked at complications rate, and they found the complication rate's up to 25%. Here's the problem. Some of those bone grafts resorb. But here's the other problem. About 2% of the time in some of the published studies, you see a nerve injury. That's a never event. We cannot have a nerve injury. And that's why it will never be adopted widespread in the US, because the environment just won't tolerate it. But I've knock on wood, not had one, but I've known surgeons that are way better than me that have, that are incredibly meticulous, and you have one of those and you're looking for another reason. So in my hands, I like a ladder J very much. It works. It's a very good operation. But the bone does resorb just a little bit. So if you're asking me what it is, I would say this. We now know that same group, there's not very many studies, but a couple of studies have directly compared ladder J versus Bankart remplissage. The best of those is 2019 AJSM, but lead author is Yang, but that's Arciero and Mazaka's work. And they compared ladder J versus remplissage. And the results were about the same, except if it was a contact athlete, the remplissage had a 30% failure rate, and the ladder J had a 0% failure rate. If it was a revision, the failure rate was much higher in the remplissage. Okay, so those two and throwing athletes also were different. So you have to be a little careful about how you apply those things. I think the remplissage is an excellent step forward, but it's not every step forward. And here's the problem, Rob. It's so easy and so slick. The technique we've developed and others have developed, it's so easy that it's like the siren song going, JT, just come in and just do this quick one for 5 minutes. Don't worry. So that when you tell an orthopedic surgeon something slick, easy, and he or she can bill for it, look out. And that made me nervous, but I will say the data is a little better than I thought it was going to be on overall.
Nice. So I'm going to give you a scenario here. Let's say you have a professional football linebacker, 29 years old. Is that old? That's pretty old for a linebacker, isn't it?
It is.
Yeah,
Okay, let's say 27. Let's say 27. But it's first time dislocator. He dislocates finally then. He has never had any instability problems before. What do you tell him about surgery versus conservative care? And then my next follow-up question is, how different is that if the guy is 21, you know, his
Yeah.
first year?
A great question. There is no data comparing non-operative to operative data in an NFL population, but we have some things going for us. He's older. Much rather have that guy. That guy, you know, you have to actually worry a little bit about stiffness. So if my reputation's on the line with that guy, again, I'm going to look at bone loss. If he's got no bone loss or very minimal bone loss, then that might be an open Bankart for me. You know, I remember a story with Rich Hawkins, who was my mentor, and he had the reigning MVP. You've all heard of him. Reigning MVP come to him, and I said, well, Coach, what are you going to do on this guy? He goes, well, I'll do it arthroscopically. Did the case, came back. I said, Coach, what'd you do? He goes, open Bankart. I said, what are you talking about? Why'd you do an open Bankart? You had it all set up for the arthroscopic one. He said, JT, it had to be right. Now that's a guy that's done 10,000 open Bankarts, 1,000 arthroscopics by then. But when your sort of deal is on the line, man, you're going to the operation that you know is going to work. So I like the arthroscopic Bankart. If that guy, that 29-year-old, 27-year-old, had no bone loss, first-time dislocator, juicy, I think he would do very well with an arthroscopic Bankart that old. 21-year-old, buddy, I'm starting to get nervous. And that takes me to the open Bankart. And if there's bone loss, then I'm starting to think about whether I do a lateral J or whether I do a distal tibia on that.
Got it. Guys, does anybody else have any questions? I always feel like I'm hogging the show here by asking all these questions. General, do you got anything? You got a question? No, nothing. The general's speechless. And we don't, I don't believe this. I'm looking at the Q&A. There's nothing in the Q&A.
JT, I think about the Dickens paper because that started quite the discussion in Greenville when you were here.
Yes, sir.
And it led to Ellen's later publication around in our scholastic athletes. But I think the thing I think back and we learned a few things. I'll let you share the pearl we learned, but with how you think about in season. So take those same two scenarios, call it whatever week 6, halfway through the season, high level collegiate linebacker, NFL linebacker, same injury, same bone loss, now what? And a little bit of, because I think that's where Dickens and Ellen's work helps us to think a little different about what we're seeing and how we advise our athletes, maybe not on the initial decision, but the management of it.
Yeah, I love that question. I love this conversation. The in-season instability. You'd be amazed. It's very geographical. In the US, most people would say if it's in season and they can play through it, go ahead and let them finish the season. In Europe, the answer is absolutely not. Take them to the operating room right now. And what's weird is they're going to do a lateral J anyway, so who cares? It's the same operation. You're not worried about it. So I'm a little confused by that with our European colleagues. But in the US, most people would say if it's an in-season athlete, we'll get into it when we talk about the Delphi paper a little bit later. We couldn't get consensus but nobody wanted to operate on the in-season athlete. Okay, so here's the deal. Greatest papers in the literature right now in the high school population still remains Dan Buss's paper, 2004 AJSM. He looked at a high school athlete population, and they all met well. Most of them got back. They got back fast. 2/3 of them redislocated, and most of them required surgery at the end of the season. When we repeated that study in a collegiate population, a different paper, lead author still Dickens, all of us are on that paper. We looked at it in a collegiate population, and we looked at them in season. They got it back even faster, a couple of days, and most of them redislocated. And at the end of the season, then we had to discuss this thing. So then the question became this. Our mantra back then was, okay, guys, it's okay to manage these guys non-operatively. We get them working. Their apprehension has to disappear. You guys have to tell us when they have protective strength and they've got good proprioception to be safe enough to do it. But look, let's be honest, they're coming out again at some point because they're fine until they're not, right? So the real question becomes, I think we'd have kind of a consensus that said most people would say, we'll go ahead and let you play through the season if you wish. And that's probably safe. You'll probably have another dislocation, but we don't know that 2, wrecks you. But we don't want 4. We don't want 6. But a single one, it's worth trying. And then I love my favorite sort of guidance on this came from the late great Champ Baker, God rest his soul. Is you guys in the South know him at the Houston Clinic and a legend. And Champ used to say, listen, I'll figure this out for y'all. He'd say, you do not have to fix them after the first dislocation. Just fix them before the second. And I always thought that was brilliant.
Yeah.
But the truth is most of us are comfortable letting them go back. And that's proved out in those big studies. The challenge becomes, okay, season ended today. Now what? Do we fix them or not? And from this first, the take-home message from that paper you started with, Rob, is we tried in 10 of those patients to manage them non-operatively, and we were terrible in that collegiate population. So it was a self-fulfilling prophecy. All of us surgeons said, look, man, you got to have this fixed because you're most likely, you're only going to have a 40% chance of getting back. We need you to be right. We better get this done right now. Everybody gets operated on. Then I went back and we were having this conversation with Ellen one day. And Ellen goes, yeah, actually, that you're not right on that. And I'm like, what do you mean I'm not right on that? Ellen, here's the data right here. You're a data gal. I'm a dork. Let's go. And she looks at me and goes, she goes, JT, you're not even seeing these kids. They're never even getting to your clinic. So you don't know what you don't know. And I'm like, I've known her long enough where I'm like, when she says something that emphatic, you better take a step back, right? So I'm like, well, what do you mean I'm not seeing them? I see every instability patient who wants to come through the door. I'll operate on every one of them. And she's like, they never get to you guys. We manage them and they get back, at least in the high school population, and they do fine. And I said, that is a bold-faced damn lie. There's no way that's true. Let's go. And I'll be darned if we didn't look. And that's the subject of the second paper, the NISIS score. The first thing we did is we at the time, Chuck and Ellen had set up a high school athletic training network, which I think was one of the great and most underrated contributions to sports medicine that I've ever been seen and been a part of. What they built down there was 53 schools. They standardized what all the athletic trainers collected. They got all that data, and they continue to answer questions. And I was part of lots of those studies, but that was Ellen and Chuck's work of kind of getting that going. Well, this is one of the first ones we did out of there. And she goes, okay, tough guy, here you go. So we look at all these patients, and I'll be darned if she wasn't right. The orthopedic surgeons never seen them. They got back. Now, this is the interesting part about that second paper. And this is not technically the NISIS paper, but a paper before that. And she said, let's look at it. And here's what her definition of success was, because this is who Ellen Shanley is. She said, okay, here's the deal. We're going to say that in order to be successful with non-operative treatment, which I told her was going to fail, she said, okay, in order to be successful, here's what we're going to do. We're going to call success only if that player finishes the season, does not have an operation, and goes back and plays, you ready? The entire next season with not missing a single practice or game. Not one practice. If you missed one practice, my shoulder hurts, you're out. It's a failure. I'll give you that. And she did that, and they were all successful. And what that taught me was, first of all, is shut up and don't think you know everything. That's one of the things it taught me. It's amazing how many times I have to learn that lesson. But that one was one of those that I was like, holy smokes. Secondly, it teaches you, again, we're partners in this, and the physical therapists and our trainers have a perspective that we just don't have. And it's, in this case, far more valid than mine was, secondly. And thirdly, it helped us answer a key question. So now I tell patients, they ask me, well, what do I do at the end of the season? I say, it depends on your level. If you're a collegiate, we need to fix you. But if you're a high school athlete, especially if you're a junior, yes, we'll offer the chance to fix you. But at least based upon this data, you probably can get back and play pretty well.
Good stuff. Good stuff. Well, let's get into this one then. Let's get into our second study. This one, you are the lead author on it, JT. It's Non-Operative Instability Severity Index Score, or NISIS, a simple tool to guide operative versus non-operative treatment of the unstable shoulder. You were talking about it already. Study was to evaluate cohort of scholastic athletes, high school athletes who sustained in-season instability episode and attempted non-operative management, specifically looking at the likelihood these athletes could complete a subsequent season without time loss to shoulder instability. So obviously, like we've been talking, if you get this one wrong, it's going to it could potentially create a lifetime of problems for them if it's not taken care of initially correctly. So controversial topic for sure. What are your main concerns when a patient or athlete chooses non-operative treatment for the first time? What's your biggest concern? Obviously they dislocate, but any other huge glaring things?
Yeah, my biggest concern is a kid I saw this Monday, kid from Washington State, a farmer, young farm kid. He's the biggest stud in his town. He had a dislocation in high school and didn't tell anybody because he's a tough guy, kind of figured out how to do it on his own, had 50 of them. 50 of them. By the time he got to his
Ouch.
orthopedic surgeon, who's a very renowned and an excellent orthopedic surgeon, he did an arthroscopic Bankart plus remplissage, but the Hill-Sachs lesion was too big, it failed. So I just did him this week, and I put a bone graft on his glenoid side, and I put a giant bone graft on his humeral head side with a massive open procedure. I don't want to take down the subscap in a kid like that. So and then I got to worry about it resorbing, and if it resorbs, then that screw is going to be prominent. And what may have been with that first time dislocator, or maybe the second time dislocator, what may have been something that you could treat, and it's a bad memory, and we all laugh about it later in life because you got this scar. This might be something that ends his, competitive career, maybe even affects his job, right? So I mean, for those of us that do this surgery, the big stuff, you look and you think, man, if that can be prevented, we love that to be prevented. So that's the scary part, is that the more times you dislocate, it's not benign. Maybe you can get away with one in that in season, but if it's starting to come out again, especially in your sleep or lesser amounts of trauma, you're creating bone loss, and bone loss is really a difficult thing to deal with.
Yeah, JT unpacked that a little bit. I think it's really important when I think about what I've learned over time is, I was struck. We followed up on a lot of these kids. We tried to figure out what happened to the ones that failed, and we just had a hard time getting them back. But when we asked the WOSI score, that 8th question of how often does it come out and slip, not the dislocation, how often does it slip, all of them. We brought about half of those cohort of this NISIS cohort back.
Wow.
Every single one said, "Oh yeah, my shoulder slips out all the time." So how should we think about counseling our patients of, hey, here's what you need to know as you go along in life, whether operative or non-operative, but in this non-operative cohort of, hey, if this happens, because I think instability is different from almost every other orthopedic condition I know, that actually the worse it gets, the less it hurts.
Yeah.
It's sort of weird. So how should we think about counseling our patients or our athletes that are going back to sport? They're super competitive, and in that spot, how do you think about that?
I think you bring up a really good point, Chuck. The patient who I worry about is the patient that goes, yeah, it pops out on me and I can get it back in. Well, that tells me that it's easy, right? And if it's easy, that means probably you're developing bone loss. And the problem with that is that the results of the treatment of that are okay as long as it's mild to moderate. But if it starts getting bigger and bigger like they do, then you can really run into trouble. So I would say this, that a subluxation or a quote slip is the same pathology as a full dislocation. It's not different. And if it comes out on people easy, especially in mid ranges, so if you trainers and therapists out there, if that patient is up here in this really big position, Hawk used to say, right, either you get apprehensive or I do. That patient that goes, oh, like that, then I'm getting nervous even if they're not. But that's not the one. The one is that patient in mid-range instability down here or down here where anything out to the side, or they do silly stuff, what comes out in their sleep or carrying their book bag. Be careful. That's one that's tricky on those things. So I think you're exactly right, Chuck. And I think that's a different animal than the patient that we'd say, hey, we might be able to NISIS you along for a season to play. I think that's a really important follow-up study to the NICE or to the that non-operative management study, kind of going. But we know this is controversial. We'll get to the Delphi study in a minute, but I will just tell you that when we surveyed all of the so-called experts in the American Shoulder and Elbow Society, we had a really hard time coming to consensus. That's the spoiler alert on the next paper we'll get into. So, but the question then became is, okay, well, how do we counsel these kids, and how do we counsel the coaching staff and the families and everything else? And so Ellen and Chuck and I sat down with our team and said, well, what if we could come up with a way that would predict it? So we said, okay, let's look at this group of patients, these non-operatively treated group of patients, and then let's figure out individual factors that cause them to fail. So as you can see, the biggest one was whether you're a contact athlete. The odds ratio in that, I think, was 23.4, if I'm not mistaken, somewhere in there.
You're right.
And then, and here's the other thing about the NISIS score that's interesting. It's the first study that shows that older kids, all the other studies showed younger is a big risk. But that's because you're looking at a scholastic kid. The older kids in this group were more at risk to redislocate, probably because they're running faster and they're hitting harder, right? Mostly football. Okay, so the age and then the activity level in that regard, right? Contact athlete kind of sport were important in that regard, and then bone loss, et cetera. And from that, we were able to come up with a score. And then if you're above a certain score, we'd say, gosh, guys, I don't think this makes great sense for you to not do it. So I think that was the value. I still use that as a score predictor to educate patients. The one thing I will say, though, is that if you look at the table down there, a little bit lower in the paper there, it's always good to go to the data and the tables because that tells you the truth. Look at the odds ratio of that contact athlete. It's so much higher than everything else. It's overwhelmingly the biggest risk factor for us. So
Yeah,
in and of itself, in and of itself,
For sure.
you gotta be really careful about that contact athlete that you treat conservative.
Yeah. So the other factors: type of sport was the largest, age, bone loss, type of instability, arm dominance, and sex. In that order. Most important to least important. Yeah. Yeah. Good.
So how do you use that now, JT? Like you're pretty systematic about how you think about it.
Yeah. Well, one of the reasons that I love about this that you'll see in this paper, when we took a look at the individual risk factors, you'll notice that we look at it. It only requires an X-ray, right? So it doesn't require you to have advanced imaging like so many of our other studies do. And so what I would say is one of the reasons we really like this, and one of the reasons we didn't add MRI and CT scans is we don't want this decision having to go to the orthopedic surgeon and the follow-up, and then do you have insurance and can you get an MRI? We wanted this to be available on site for the trainer. Everybody can get an X-ray. So on site for the trainer, for the therapist. So that's your bone loss gig. But we wanted this to be straightforward enough where people can make this in real time on the sidelines in the training rooms without any other information. Because if you take a look at this paper here and look at it, even the bone loss on this gives you 2 points, right? So you could probably assume or not assume you're going to be somewhere between it, and it's going to be plus or minus 2. All the other points, type of sport, age, type of instability, arm dominance, and gender or sex, all of those are immediately available to the practitioner right now. And that's I think that was the value of this, is it doesn't require you to go to the hospital. You make this diagnosis in the training room or on the practice field.
Great. JT, you mentioned earlier that, as people get older and they're playing like contact sports, they hit a little harder. Is this score, do you use this same score on college football or contact athletes and pro athletes, or do you get a different score, or even use a score like this? Because it would be different for college and pros, right? Because they're a different animal than a high school.
They are, and that Dickens paper that we talked about a little bit earlier showed us that we were pretty unsuccessful with the non-operative management folks treating them, with that. I think with big numbers, there might be a population of people that might be able to get away with it. I will say this, in hockey, given that high sticking is illegal, but I would say they get a lot of shoulder instability from getting hit and knocked on the floor. I was surprised, as opposed to football, just how a little bit more reluctant those guys are to have first-time dislocator bank carts than are some of the other sports that we've looked after. So I think it does sometimes depend. And as you know, Rob, and you guys that look after some of these athletes, what we're recommending is going to be dictated to us by that agent sometimes, and by now at the high school level, that NIL money, or they all got agents now. And so then it becomes even a bigger conversation, and how difficult that is sometimes. And they're thinking long term. I will say, after looking after a professional athlete population, I learned that it is really, really not very different than workman's comp. And we all know that the results in workman's comp are not. Those guys are looking long term. How do I stretch this contract out as best I can? And so that makes me miss the days of the military where you're trying to talk guys away from, hey man, you gotta give me a little time here.
Yeah, great stuff. Hey, JT, usually we get some questions from the people that are online. We've got a couple. I think hopefully you'll understand this more than me. What is free fall? Is free fall like in the military? Is that jumping?
Yeah. So that's elite. elite troops, usually we do static line. So for example, if you're a 11 Bravo, which is an infantry person, and you're going in and you jump, your little chute is hooked up to the thing, and you got some guy that looks like George that says go, and you go, I don't want to go, and you go, right? And then that parachute deploys. But for the more elite of our special forces and athletes in that regard, they will do, I mean, high altitude, low opening, halo jumps that you've heard of. A lot of that population will go down and you're falling. You don't want to be here. So that's the person we won't manage non-operatively, because that, you know, skydiving in that position, kayaking and certain rock climbing, your shoulder goes out. It's a life-threatening event.
Yeah. So the question here, we got a question from John Hill. How do you approach the tactical operator who is dislocated and needs to get back to free fall? Do you lean toward open repair or arthroscopic? And where does age start to affect the decision in the person who needs to get back to free fall?
Yeah. So the free fall, you got to be in a certain position. You don't have to be like a pitcher, but you do need to get to kind of 90-90 in those positions, right? You've got reserve shoot. Usually that's in front, but you know, some of the things you want to be able to move, but you got it. You put a premium on stability. So in that patient, I'm much more likely, I mean, if it even sniffs of a bone loss case, that goes right to bone grafting or Latarjet or open Bankart.
Pretty quick. All right. Mohammed Jamali is asking, is soft tissue or bone morphology to be blamed for those who have spontaneous subluxation or dislocation? And is Tubbs and Ambray concept a still relevant dichotomy?
I love that question.
Good question.
The answer is it can be both. I would say this: developmentally, posterior instability is sometimes related to bone, retroversion, posterior dysplasia, etc. But anterior and multidirectional is much more likely associated with soft tissue. So most of the time you get that young gal who's 15 and a gymnast, she's already flexible. She wouldn't be a good gymnast if she wasn't. She's all over the place. She's got a little bit of a small glenoid, but she's got her ligaments are just so lax, right? Just finishing puberty. It's going to take them a while to tighten up. That's a soft tissue problem. The posterior ones where you sometimes see these cats that are pretty atraumatic, that patient's going to come in. I think Tubbs and Ambry still has a role. That traumatic unidirectional sort of instability is a different animal than the atraumatic multidirectional patient. I think that you guys are, I think the Tubbs patient, if you will, is a harder gig with rehab, because it'll be fine. You'll get them feeling perfect. They'll come back. How are you feeling? I'm a saint of 100, right up until they unexpectedly come out again, right? You guys have all seen that 100 times. The Ambry patient, I think, is a little bit more amenable to scapular work and the things that you guys have taught us so well about lower trapezius and serratus anterior and getting that scapula as a platform. Many of our MDI patients, when we say, can you put your shoulder out? They say yes. And what do? They pop their scapula off the back, right? So if we can teach them, you guys teach them to get that scapula in a better position, those patients, I think, sometimes can be cured. If not, it's a little bit of a different operation. You have to address the laxity. So we go all the way around the world with those kids.
Gotcha. All right, let's hit our last, we got like 15 minutes left. Our last study, decision-making and treatment after first-time anterior glenohumeral dislocation, a Delphi approach by the near circle of the American Shoulder and Elbow Surgeon Society. Barb actually wrote these questions. Barb, do you want to ask the questions, or do you have them in front of you, or want me to go ahead and do it?
Sure.
You got them?
I'll start with my first one, which is kind of a fun one. So, Dr. Tokish, tell us a little bit about the near circle, and for the youngsters on the call, a little bit about Dr. Neer and his legacy. And then kind of like how this Delphi study kind of came into play and how it came to be.
I love that question, Barb. Thank you. This is something I love this story. The near circle was started with this paper. It was the first project, and it's really the credit should all go to Frank Cardasco. He was the president of ASES at the time, and he said, you know, we need to have maybe a smaller group of people who have demonstrated service to ASES, and to be able to guide the presidential line, and to be able to sort of help the organization going forward with important topics and events. That was kind of the mission behind it. And then he said that one of the tangible ways we can do that was, he said, we could come up with a yearly question that doesn't have a great answer, and then we could get consensus on this. And so he asked me to lead the project along with Jed Kuhn. And so Jed and I co-chaired the project with it, along with John Ticker, and a host of others. And so the Near Circle was founded. And now if you go to the American Shoulder and Elbow Society meeting, we have a separate Near Circle meeting. And every year we have a day. One half of the day is spent discussing whatever the paper was that year. It's been fracture, it's been dislocation of shoulder arthroplasty. We've had a number of these questions now, but this was the first one. And then the second half of that Near Circle day is talking about things that are important to the future of shoulder surgery. It's named the Near Circle in honor of Charlie Neer. Charlie Neer was, many people consider to be the father of American sports shoulder surgery. He was the first person to have a shoulder fellowship, and we're proud because Rich Hawkins, who's been many of our mentor, but certainly my mentor for sure, Chuck's as well. Hawk was Neer's first fellow. Being somebody's first fellow is quite an honor. And the story behind that in 15 seconds is this. Hawk was at Western Ontario, and Jack Kennedy was the head of the service then. And Kennedy, who was the chief, came to him and said, Rich, you're going to go away and do a fellowship in shoulder, and then you're going to come back and join us. And back then, I guess you could say that as a chair, and all you said was, yes, sir, and you came back. So he said, oh, yes, Dr. Kennedy, who am I going to do my fellowship with? He said, you're going to do it with Charlie Neer. Okay, that's great. So he says, great. He makes a phone call. He says, hi, I'm Richard Hawkins, and I want to apply for Charlie Neer's fellowship. And they said, well, Charlie Neer doesn't have a fellowship, and he doesn't take fellows. So he goes back to Kennedy and says, Dr. Kennedy, Dr. Neer doesn't take a fellow. He goes, don't worry. His buddy is Bill Norrie, who is a spine surgeon. You're going to go out and do a spine fellowship first, and then you're going to impress him so much that you're going to get him to take you on the shoulder service. And that's exactly what happened in the start of the world's first shoulder fellowship. Neer had many landmark papers, but many of them were shoulder arthroplasty, the 4-part fracture classification. I mean, non-operative instability. I mean, it just goes on and on and on. And his legacy and it has laid out the presidential lines of many, many folks that have followed in that line. So that's the story of Neer, the story of our little kind of connection, Chuck and mine, with it, and going forward with it.
I just love that. And I think that people on this call need to know that presidential line and need to know about Dr. Neer, as well as all of the people that he has influenced and so on and so forth. So I have a question sort of for Dr. Tokish and Phil. Phil, I'm calling on you, Philly. Speak to why a Delphi approach was appropriate for this and why it was utilized for the describing an intervention that really is not well agreed upon, and why it still has its problems, as well as why it's legit when analyzed statistically. So talk a little bit about the approach and why you chose it.
You want me to start, or Phil? Maybe you're more qualified than me to talk about this.
Doc, I want to start by saying this was one of the best Delphi studies I've ever seen.
Yes, sir.
And how you structured it. You went to the nth detail, and you took the hard route with this Delphi. You started, just to let the audience know, that the Delphi is usually a 3-phase study with a group of experts that try to come to a consensus. And of course, as you know, coming to a consensus is difficult to begin with. But what you started with, which I loved, was open-ended questions. What do you think about this? And then, you develop this kind of, okay, what are the approaches? And then you do a Likert scale with it, and you analyze that for correlations to build scenarios. 169 scenarios?
It's ridiculous number.
Sorry, I had 160.
I'm sorry.
There were 162 clinical scenarios and 163 complaints about how long the survey was.
I was going to say, how did you get 70 orthopedic surgeons to complete 162 scenarios, Doc?
Begging, pleading, and etc. A little bit of twisting.
Great job, JT. Great job. I think this was a fantastic study. And to answer Barb's question, the results are in the analysis you guys did. The statisticians that you worked with did an amazing job with the stuff. So kudos to you. This is a great study.
Thank you. That was Jed. Jed had a guy, and Jed is a brilliant mind. Way more brilliant than I'll ever hope to be. But he and his statistician kind of crammed it through, and then my job was to kind of help with getting the surveys organized and kind of taking us through the Delphi process. You guys may know this, but Delphi was started right after World War II by the RAND Corporation. The Department of Defense was looking around at the new world we were living in, the post-World War II, and said, look, we've got to have a way, because the truth is we don't know how to face the Cold War. We don't know how to face the Eastern Bloc. and nobody's got the perfect answer. So we need to come together and figure out a strategy by which we protect America kind of going forward. And out of that was this process. And you're exactly right, Phil. First one is you don't want to make assumptions. But I'll tell you the story of this. When we had our first meeting of the Near Circle group, of the organizing group, myself and Jed, Bob Arciero was there, Frank Cardasco, and I'm not going to mention who said this, but they came together and they said, look, the purpose of this is we need to educate everybody that we have to operate on the first time dislocator. So the purpose of this thing is to get together so we can educate our colleagues that we've got to operate on all these guys. And I remember Jed and I looked at each other and kind of out of the corner of our eye and said, that's not really what a consensus is. And we were both like, we're happy to report it, but we were both like, I don't think you're going to get the kind of consensus you think you're going to get from these so-called experts. So we go through the process, and you're right, we first start out by doing it. And then the second one is the Likert scale. And actually you provide the expert group with a literature review, sort of a level setter to make sure that everybody's read what's out there in the literature. And then of course you break it down into scenarios. And as I talked about, I got Bob Burks probably chat me once, so he does anyway, but he probably chat me once a week saying, this is ridiculous. You're trying to kill me. What are you doing to me? Blah, blah, blah. And I said, just please answer. And we were lucky. We had really high fidelity with it. At the end of the day, what you guys found was what we found, which is we couldn't get much consensus. In other words, in order for us to get everybody to agree, there were only something like, there were less than 20 scenarios that we could get people to agree to operate. And you had to have everything for everybody to agree, or you had to have nothing for everybody to agree with non-operative. Any one of those factors, bone loss, in season, type of sport, et cetera, you go south on one of those factors and you change it. In other words, it's not a complete royal flush on all the risk factors. Okay, we'll agree. None of the risk factors. Okay, we'll agree non-op. But anywhere in between, we were idiots. We couldn't come up with any kind of consensus in that regard.
Amazing. Kudos to you.
I love it. Yeah, for
Beautiful.
sure. And so if you would just sort of summarize for those of us who want to hear more about it, the findings about what conditions and factors most likely would result in consensus.
Yes.
And then kind of comment on, do you think this is the state of the state, or do you think it's kind of not the state of the state at this point?
Yeah, I think the consensus is still building in that regard. I think because there is a failure rate with operative treatment of shoulder instability, right? So I think many patients, I think, as we talked about, I think we only achieve something like 15% or 14% consensus for recommending non-operative management. And all of those scenarios, you couldn't have bone loss. You couldn't be, if you wanted to get a consensus on operating, they couldn't be in season because everybody said, no, let them play. They had to have bone loss, because if they didn't have bone loss, people would say, well, let them dislocate again, right? They had to be an athlete. They had to have apprehension. So many of those things were predictors of our surgery in that regard. And if, again, none of those were predictors. So in other words, if you were an in-season athlete, if you didn't have bone loss, if you weren't a contact athlete, then we could agree all those things. But anywhere in between, it just didn't come. So it just goes to show you that even people who live their life managing these patients still disagree quite a bit. Now, I will say this, that one of the criticisms, if I was criticizing this paper, I'd say is we didn't include therapists. These are all surgeons. And we just learned the lesson. I was just talking about the lessons a minute ago, was that the therapists have a perspective that is correct about how to manage non-operative versus operative management. And we talked about that. We did argue about it, about bringing in some of the therapists. That the reason we didn't was the group felt that it was important that somebody that was on that panel needed to be somebody that managed the entire spectrum, to include surgery. And now here's the funny part. All the surgeons say, well, we also manage it non-operatively. And I think that's where you guys could make a criticism, because do we manage it non-operatively? You guys, we send them to you. And so I think that is a fair criticism of the paper, but we still, we make decisions about this management operatively and non-operatively. So we're proud of the paper for sure, but I suspect that we'll have more of those kinds of questions to follow up on.
Really good information. And I think, when I was thinking the same thing, it's like, what would we as therapists think about this? Like, if you were to do another Delphi that looks something like this, and you got the experts or the who's who of physical therapy to do the same sort of thing, would we come out with again, we don't recommend surgery, but how could we have consensus on non-op management? And the answer is probably would be pretty similar to what you found, is my guess.
I would love to see your guys' group do something like
What do
that.
you
And you
think,
wouldn't have to
General?
necessarily say surgery, but you could say, which patients do you feel you can successfully get back
Right.
with non-operative management, right? And that
And
would
even
be a really interesting take.
and even those thoughts that Ellen brought to the table that you said, you know, the ones that you guys don't see, you know, how would we describe some of those things, or could we reach some form of consensus? And my hunch is it's going to be pretty doggone similar to what you saw, you know.
What do you think,
We tend
General?
to-
You think that's accurate? We would not reach consensus?
Absolutely.
That's what, yeah. Yeah.
That's my thought
It would be
too.
tough, yeah.
Yeah.
All right, guys.
So I had
Ash, you got
yeah,
one
we
more?
got-
We're gonna
No, I don't. I was just gonna say I had other questions, but you've already addressed them. So kudos. Thank you. It's about
Yeah.
age and bone loss and all that kind of stuff. So we've already got to them. That's great.
So
Thank you.
JT, just so you know, before we go, our biggest group that has been on here since we started was just last month with we had
Rachel Frank.
Oh,
and she
well,
had
she's way
300
better than me.
well, she had 322 people. You actually beat her by 6 people. Way to go, man.
You topped out at 328.
Yeah.
Look at that.
Well,
328.
that's because you guys were on here. Rachel is way better than me, and hopefully next month will be even greater. We'd love to see this thing blow up, and I'd love to. You might, if you can advertise it and allow our fellows to come on. I think our fellows would
yeah.
benefit from this, and
Of
residents.
course, man.
So thanks for allowing us.
Can we have
wish
you
great
can we have you
continued
back
success.
sometime?
100%.
All right, buddy.
Dr. Tokish, we have a goal of having to upgrade our Zoom account beyond the 500 person limit. So if you help us get that goal.
How many hey Ash, how many did we start out with though? Our first one, how many do we have? Like
Oh, I don't know.
50
maybe,
or something?
yeah, under
Yeah,
100.
Yeah.
Mhm.
Look, I'm just on here for the pupper. You show that pupper,
Yeah,
I'm coming on. I'll join you anytime you want.
He must like you.
He's ready for
That
you. You can see it.
puppy.
He said, "Mama, it's time
He's
to
like,
be done
Mom,
with
it's
this thing."
time. You've
Yeah.
been at your
Yeah.
desk all day. Thank you so much for coming on. And yes, for those that jumped on late, this is recorded. It will be on YouTube. It will be on Apple and Spotify podcasts. Dr. Tokish, I'll send it to you so you can share with
Thank
your
you.
fellows as well. So thank you again. And we'll be back next month. We'll be getting emails out here very soon about that and what papers we're doing. And we'll have Dr. Tokish back on hopefully very
For
soon.
sure,
So
for sure.
thank you, everyone.
Thank you.
Thank you, everybody.
Thanks, guys. Good to see y'all.
Thank you.
Thank you.
Thanks a
Thank you.
bunch.